Hello and welcome to Lupus and the Need for New Lab Tests. I'm Annika Hazlitt, a member of the Board of Directors of Kaleidoscope Fighting Lupus, and your host. Lab tests and biomarkers are important diagnostic tools for lupus patients and their healthcare providers. Yet, even as medications and therapies have advanced significantly in the last several years, there has not been similar advances in the kinds of lab tests that are commonly used or authorized to diagnose lupus. Here to explain this gap and the need for new and improved lab tests is Dr. Don Thomas, a clinical rheumatologist and the author of the Lupus Encyclopedia. Before we begin, we thank our community sponsors, Pharma, Tin Rocket, Blue Eyed Crow Studio, Due North Studios, and 7 Minute Cinemas for their generous support in making this educational video possible. Now, let's hear from Dr. Thomas.
Thank you very much for that kind introduction. Thank you so much for watching this video. The topic I'm going to talk about during the next 30 minutes is dear and near to my heart. I'm just hoping that patients who are watching this, I hope this will get you riled up and angry that more is not being done for this topic, and hopefully some of you will have the know-how to be able to make some change. And I hope that some of you watching this are physicians or people who have influences with the FDA or the central Medicare and Medicaid services departments, so that change can occur, so we can do better in diagnosing and managing lupus patients a lot better. So first, I'd like to tell you about a patient I just saw a few weeks ago. Her name is Michelle, and she's 18 years old. This photograph is not really her. Her name's not really Michelle, but this photograph I got off the internet kind of made me think a lot about Michelle when I saw her. Well, Michelle gave me this story about how 3 years earlier, she got very sick after a beach trip. She had a lot of horrible pain and stiffness and swelling in her joints and was horribly fatigued. Well, she had some laboratory work done, and she was found to be both anti-nuclear antibody positive and rheumatoid factor positive. She was seen at a couple of the best children's hospitals in the area and in their rheumatologic departments, and they really weren't sure what was going on with her. And so they ended up diagnosing her with juvenile idiopathic arthritis. Juvenile idiopathic arthritis, you can think of it as the children's version of adult rheumatoid arthritis. You know, the laboratory test results that she had done were not very helpful. Anti-nuclear antibody, or the ANA test, we oftentimes think of it as the lupus test, which I hate because it's not really the lupus test, but 30% of rheumatoid arthritis patients are positive for ANA. And then when we look at our lupus patients, 30% of them are positive for rheumatoid factor. So we can't think of it as being the rheumatoid arthritis test. And so she was diagnosed with JIA. And the drug of choice for JIA is methotrexate, and so she's placed on methotrexate to help out, and also prednisone, because prednisone is the only thing that helps out immediately. Well, the prednisone helped out phenomenally. She was placed on prednisone, I believe it was 20 milligrams a day, and also 25 milligrams of injections of methotrexate per week. But then as they were tapering down on the steroids or the prednisone, she would start to get mild flare-ups, and they'd have to keep going back up on the prednisone dose. But then a year into her diagnosis, she took a trip with her family to the beach. She got very sick. Her arthritis flared up, she became incredibly fatigued, she developed a rash all over her body, and then developed mouth sores on the palate of her mouth and on the insides of her cheeks. She was put on higher doses of prednisone again. And then, they stopped her methotrexate because they weren't sure if the methotrexate might have been playing a role. Methotrexate can sometimes cause mouth sores. Methotrexate can also sometimes cause a sun-sensitive rash. And so they stopped it just in case it was playing a role. Well, they had her on a steroid taper, and as they were tapering her down on her prednisone, her steroids, her arthritis and her fatigue got worse. The rash came back. It was a sun-sensitive rash just on the sun-exposed areas of her body, and the mouth sores came back. So they were clearly not due to the methotrexate, because she was off methotrexate at that point. She also started to dump some protein in her urine. She had an excessive amount of protein of 600 milligrams per day. Normally it should be around 150 milligrams a day or less. That can sometimes be a sign of inflammation of the kidneys. But then worst of all, she started to get some blurriness in her left eye. She found it very difficult to even see with the left eye, so she went to see an ophthalmologist. When she saw the ophthalmologist and he looked into the back of her eye, this is what he saw. And I'll lead you through this on what you're looking at here. This is the retina, or the back of the eye. And on the right side of the retina, you can see kind of a round, kind of light-colored area with a whole bunch of blood vessels going in and out of it. That's actually the optic nerve. Like when we're looking at something and the image lands on the retina, there's electrical impulses that go to the optic nerve, and then the optic nerve takes those impulses to the brain, and we can actually see what we're seeing. And this is what her optic nerve looked like. Now, it's hard for you to know what this actually shows unless you actually look at what a normal optic nerve looks like. So here is a photograph on the right of what a normal optic nerve looks like. Notice how you can easily see a round structure, and in the middle part of it, there's a brighter yellow area. The bright yellow area in the center is called the cup, and then the round area around it is called the disc, and that's what a normal optic nerve looks like. And notice that her optic nerve, it was very blurry, kind of indistinct. You can't tell the difference very much between where the optic nerve starts and where the retina starts. This is an inflamed, damaged optic nerve. She was having optic neuritis. Her immune system was actually attacking her optic nerve, and so fortunately her ophthalmologist put her on very high doses of steroids through an IV, something called a pulse IV steroids. Fortunately, she felt much better. Her joint pains went away, her rash went away, the mouth sores went away. She did have some eye discomfort, that went away, but unfortunately she was left with blurred vision. It was so bad that she became blind in that left eye because of the optic neuritis. Well, folks, she clearly has systemic lupus erythematosus. We diagnose systemic lupus erythematosus by using something called the classification criteria. Classification criteria, we generally use it for research purposes, but it also helps us diagnose patients in the clinic because lupus can be so hard to diagnose. She had central nervous system involvement with the optic nerve. She had protein in her urine, something called proteinuria, which can be a sign of inflammation of the kidneys. And she saw a kidney expert who thought that she had lupus nephritis, a type called mesangial lupus nephritis. She had a sun-sensitive rash, which is one criteria for systemic lupus. She had the oral ulcers. She had inflammatory polyarthritis and a positive anti-nuclear antibody. You only need 4 criteria to say that someone satisfies criteria for systemic lupus, and she had 6. There was no doubt to the diagnosis. This was not juvenile idiopathic arthritis. This was systemic lupus the entire time. She was fortunately at that point placed on the drug of choice for lupus, which was hydroxychloroquine, not methotrexate. When she was placed on hydroxychloroquine and she was on these steroids, she was feeling amazing other than the loss of vision in her left eye. Her steroids were tapered down, and as they were tapered down, the mouth sores came back, her joint pains came back, but she also developed a painful rash. She would get these red, real painful nodules or knots on her skin, something called erythema nodosum, and the only thing that would help her feel better was with her doctors going back up on her steroids. But they also went ahead and added another immunosuppressant medicine called azathioprine. The steroids and the azathioprine help, but not sufficiently. Well, then I saw her a few weeks ago. So when I see her, here she is, 3 years later, she's been having systemic lupus erythematosus going on uncontrolled for 3 years. She's 18 years old. She's a senior in high school, wanting to live her life as a teenager, and she's applying for college, having dreams of going to college. But here she is, she's blind in the left eye. She has these painful erythema nodosum lesions. She gets these painful mouth sores that makes it hard to eat. The arthritis in her hands makes it hard for her to type and write. She has to stop typing after a while. She has trouble finishing her homework because of the pain in her joints and also the horrible fatigue that she has. And she's still on steroids. We say that the P in prednisone stands for poison. Even though steroids like prednisone can be life-saving in our lupus patients, like it probably kept her from going blind in the right eye, nonetheless they cause permanent organ damage in every patient who takes them for any length of time. So we have really failed this person. We have failed Michelle as someone with lupus. We should have been able to diagnose her that very first time we saw her with systemic lupus, but we couldn't. And that's because our laboratory tests and our diagnostic tests for lupus are just so horrible. And I'll tell you that information in just a little bit on why that's so. So first, though, let's look at some other statistics. When we look at systemic lupus patients and look at the percentage of our patients who get organ damage from their lupus, at 1 year, 1 out of every 3 lupus patients will have permanent organ damage. By 5 years, 50% of 1 out of every 2. And unfortunately, Michelle is part of these statistics. Here it is at the 2-year mark is when she got the optic neuritis, and she ends up being blind in that left eye because of her lupus and not being diagnosed as quickly as she should have and being treated like she should. Also, how long does it take to get the diagnosis of lupus? We know because of some surveys that come from the Lupus Foundation of America and UK Lupus, the United Kingdom Lupus Foundation. They sent out a survey to all of their members to find this out, and both of them showed the same thing. It takes an average of 6 years from the time that someone first develops symptoms of lupus to the time that they get an actual diagnosis. So at least Michelle beat these odds in that she was diagnosed at 2 to 3 years instead of the 6-year mark, but 6 years is the average. And then misdiagnoses. 75% of the systemic lupus patients were diagnosed incorrectly during their diagnostic period, just like Michelle. She was told she had juvenile idiopathic arthritis instead of the correct diagnosis of lupus. And then they saw an average of 3 doctors along the way. Michelle saw many more than that, by the way. She saw her primary care doctor. She saw at least 2 or 3 different rheumatologists at different children's hospital centers. She saw a neuro-ophthalmologist and a regular ophthalmologist and a neurologist. So she had numerous doctors before she reached a proper diagnosis. And then the average, now we say that it took an average of 6 years to reach a diagnosis of lupus. Well, that comes from surveys of lupus patients. Well, that can be incorrect, We don't really know if they, did everyone truly have lupus? Did their doctors tell them they had the right diagnosis or not? We really don't know. But we do have some better data from actual rheumatologists themselves. A study came out from Dusseldorf, Germany by a rheumatologic group, and they asked the same question: how long does it take us to diagnose our lupus patients? Their data showed that it took an average of 4 years to diagnose their lupus patients with a proper diagnosis. Those patients who were diagnosed later, they had worse disease, and they had more organ damage compared to patients who were able to be diagnosed sooner. So just like Michelle, she has severe lupus disease and she has organ damage just like in that study. So why is this going on? Well, there are multiple reasons, but I want to focus on our inability to diagnose lupus with laboratory tests properly. This graph here, it shows the timeline for when rheumatologic labs have been developed over the years, not just for lupus, but also for rheumatoid arthritis as well. Well, the ESR stands for erythrocyte sedimentation rate, oftentimes called the SED rate or ESR. It came about in the 1800s. It was refined in the early 1900s with what we call the Westergren method, which we use to this day. Then in 1930 comes C-reactive protein. It's another very nonspecific inflammatory marker for helping us diagnose rheumatologic diseases. 1940, rheumatoid factor comes along. Well, rheumatoid factor, like in Michelle, can be seen in 1 out of every 3 lupus patients, even though we think of it as helping us to diagnose rheumatoid arthritis patients. And then in 1948 comes along anti-nuclear antibody, or the ANA test. This is such an important part of a diagnostic test for lupus patients because close to 100% of systemic lupus patients are positive for ANA. And so whenever we consider the possibility of lupus, like in Michelle, we order an anti-nuclear antibody test. It doesn't help us really make the definitive diagnosis, but it makes us look for more laboratory tests that might help us make a diagnosis of lupus. And then just a few years later, C3 and C4 complement were discovered. When lupus is active, there's some molecules of the immune system called complements that are used up. And 2 especially important ones are C3 complement and C4 complement. When lupus is active, oftentimes those levels go down. And so they can be helpful in not only diagnosing lupus patients, but helping us follow the disease activity as well. When we see the C3 and C4 complement levels come down with lupus disease activity, then we treat them and they get better. We know we can follow those patients with the C3 and C4 complement levels. But guess what? They're only helpful in 20% of our patients. 80% of our patients, they're not helpful at all, just like in the case of Michelle. And then there's anti-double-stranded DNA antibody. Anti-double-stranded DNA antibody is positive in about 60% of our systemic lupus patients, so 40% of patients is not helpful. Then anti-SSA and anti-SSB antibody, also called anti-Rho and anti-LAW, they all mean the same thing. These are seen positive in about 30% of our systemic lupus patients. We call them these different names, by the way, because anti-Rho was discovered in a patient with systemic lupus who had the initials RO. Her last name was Robert, RO. And then there was another patient with the last name Lane who had systemic lupus, and another different antibody was discovered in her, so they called it LA or LA because of the first 2 initials of her last name, Lane. But around the same time, another laboratory discovered these 2 exact same antibodies in patients with a related autoimmune disease called Sjogren's syndrome. And so that laboratory called them anti-SSA and anti-SSB. So anti-SSA is the same thing as anti-Rho. Anti-SSB is the same thing as anti-LAW. But they're all can be found in both lupus and Sjogren's, so they're not really helpful in telling the difference in most of our patients. And then finally, anti-Smith antibody was discovered in a young woman with severe systemic lupus. Her last name was Smith and she was an artist, but anti-Smith antibody is only found in 25% of systemic lupus patients. Folks, the labs that I'm showing you right now, these are the labs that 100% of rheumatologists use to help diagnose lupus patients. Since that time, there's been no other universally covered labs developed to help us diagnose and follow lupus patients. We're falling way behind on helping patients like Michelle. And yet to ask the question, is technology really that bad? Are our researchers really that horrible? And the answer is, of course, no. Technology today is just amazing. It's just phenomenal as far as the amount of technology that we have and how advanced it is. But the problem is we have a broken system. There are tons of labs that are being discovered by lupus experts and researchers and laboratories, but they're just not able to get out of the laboratory and to the clinic and to doctors like myself to help our patients out very well. And I'd just like to give you a few good examples and just illustrate some of the problems that we're seeing with getting research laboratory tests into the hands of physicians. One of those tests is called the DFS-70. DFS stands for diffuse fine speckled pattern for anti-nuclear antibody. And this, when we look at anti-nuclear antibody under the microscope, there's a lot of different patterns that we can see. And one of those patterns that was discovered, they called it diffuse fine speckled. And diffuse fine speckled pattern is made up a lot of different types of proteins, but one of them in particular was an antigen called DFS70. And what they showed is that when they tested the antibody towards this DFS70, and they called it a monospecific anti-diffuse fine speckled 70 antibody, that if someone was positive for this particular antibody, but they were negative for all other types of anti-nuclear antibodies, so Smith, double-stranded DNA, SSA, SSB, SCL70, anti-centromere, there's a lot of different other autoantibodies, that particular person had a very low likelihood of having a systemic autoimmune disease. You could think of it as being a rule-out test for systemic autoimmune diseases. So if you get someone like Michelle and you're wondering if she might have an autoimmune disease like lupus, and you tested her for this and then everything else was negative, then she would most likely not have an autoimmune disease. And that'd be so helpful for primary care doctors like internists and family practice doctors. But this is an example of where a laboratory test like this is discovered, and then it doesn't get into the hands of physicians until a lot longer after it's discovered. It was discovered and brought about by a research company, and this particular research company, this laboratory research company, they didn't know how to get it into the hands of physicians and make it commercially available. And so what did they do? Well, they ended up selling it to LabCorp and Quest. And now here it is many years later, and finally, as a rheumatologist, I can order this test. But it's only been for about a year now that I've been able to do so. And so finally, it's part of my arsenal, but it wasn't for quite a long time after its initial discovery. And by the way, many doctors don't know about this test even. We still got to educate doctors that it's even out there to help our patients out. Another important lupus test was one called the SLE key test. This was one of my favorite tests that ever was discovered for helping us with our patients who may or may not have systemic lupus. It was also called the rule out SLE test because it could actually help us rule out lupus. In other words, if someone was positive for this test, I could tell that person that they don't have lupus, which was just phenomenal. When I would get the results of this test back, this is what the results would look like. The graph that you see on the left side is someone who does not have lupus, and it's the X that you see on the graph, the bottom side of the graph. And then the one on the right is an example of someone who does have systemic lupus. And so a positive test would look like the one that you see on the left side of the screen here. And when this test became available in 2016 and 2017, I started to use it a lot, and I found it to be incredibly helpful. And I'll just give you one example. I met this young woman and her husband. They traveled all the way from Delaware to come see me. And she had a lot of horrible joint pain. She had horrible fatigue. Her life was just like it was being just stripped away from her. And she had actually seen several different rheumatologists. She was positive for anti-nuclear antibody. She had a lot of tender joints on examination. Well, a couple of rheumatologists told her that she had lupus, and they recommended that she take hydroxychloroquine or Plaquenil. But she saw another couple of rheumatologists who told her she didn't have lupus. They told her that she had a disorder called fibromyalgia instead. So this couple was really confused. I mean, what did she actually have? And the rheumatologists were not able to help her out and to tell her one way or the other. Well, this test had just become available. When I saw her, I did a thorough history and physical examination, and when I got done with the examination, I thought that she most likely had fibromyalgia. Fibromyalgia is a very painful disorder that can mimic lupus, and it's an overactivity problem of the pain nerves of the body, but we don't treat it the same as we do lupus. Well, I ordered this test for her, and the results came out exactly like you see on the left side of the screen. I was able to give her and her husband a copy of this test and tell them that I had really good news for them, that I was able to rule out lupus as a cause of their problem. She absolutely had fibromyalgia, and she doesn't need an immunomodulation therapy like hydroxychloroquine, but we need them to focus her therapy on fibromyalgia therapies. and not lupus therapies. It made a huge difference for this young couple, and I saw it the same for many other patients that I saw as well. Here's some additional statistics about this particular lab. When they did the statistics as far as how this test could exclude the diagnosis of lupus, it had a sensitivity of 94% and a negative predictive value of 93%. And those are a lot of big statistical names. I'll just say that these are the results for a really, really good test. But then something happened. You know, the company that made the SLE key test, they were a small company like most biotech companies are down in Richmond, Virginia. It's an incredibly expensive process to get a laboratory test that's discovered in a research lab and then have the money to be able to afford to get it through the regulatory processes in order to get it approved by the FDA and by the Centers for Medicare and Medicaid Services to become available to doctors like myself. This small company, even though they had this amazing test, they were not able to afford to do that. The company went bankrupt. And today, this test is completely lost and we do not have it available for doctors. Just think about it. What if internal medicine doctors and family practice doctors who saw patients like the one I just mentioned and who were positive for anti-nuclear antibody, just think if they could have ordered this test and be able to rule out a diagnosis of lupus and not even have to send that patient to a rheumatologist, but be able to diagnose them with fibromyalgia themselves and take care of the patient properly. Well, we don't have that available. And then the third test I like to highlight. This test actually, by the way, is available, but the vast majority of rheumatologists do not and cannot order it. The vast majority of insurance companies won't cover the test, which is a travesty. So this test is called CB-CAP. CB-CAP stands for Cellular Bound Complement Activation Products. So remember I mentioned that complements are important in helping us diagnose and monitor lupus patients. When lupus is active, complements are used up and their levels go low. But there's a huge problem. The liver, which is a great organ for manufacturing these complements, when there's a lot of inflammation going on in the body, the liver churns out a ton of complements. And so here we see these complements levels going down because lupus is active, but then the liver is churning out a ton of additional complements. And in most patients, those things balance out. And so in most lupus patients, their complement levels are normal or high and are just not helpful at all. Like I mentioned earlier, they're only helpful 20% of the time. Well, in the early 2000s, Dr. Susan Manzi, who's a lupus expert in Pennsylvania, she discovered that complement would bind to the cell surfaces of blood cells, so cellular bound complement. And the complement would stay on those cells for the lifespan of those blood cells. And so she figured out a way to measure that type of complement instead of the complement that's floating around in the blood. And she proved that it was a lot more specific and sensitive and helpful for diagnosing lupus patients and following them than the old-fashioned C3 and C4 complement levels from the 1950s. So a company called Exogen, they got a hold of her technology and they thought, this is amazing. We'll be able to help lupus patients all over the world with this amazing technology. So they came up with this test called the AVISE SLE test, or the AVISE lupus test, which is a way that they figured out even better how to use these CB caps to help diagnose lupus patients. And they devised this AVISE SLE test and another similar test called the SLE monitor test that used these CB caps to help out our lupus patients. And I've been using these tests a lot since the time they first came out in 2012, 2013, and found them to be incredibly helpful. To show how good tests are in diagnosing and following patients, we can look at a statistical result called the sensitivity. The sensitivity for lupus patients using anti-Smith and anti-double-stranded DNA and complements are shown on this slide. And these are the exact tests that were used in our patient Michelle and used for almost all lupus patients around the entire world. These old tests from the 1960s and older. Anti-Smith has a sensitivity of only 10 to 30%. Anti-double-stranded DNA has a sensitivity of only 32%, and C3 and C4 complement combined have a sensitivity of 44%. But this test called the AVISE SLE test by Exogen that uses CB caps, it has an 80% sensitivity. Just think of that, much more superior than all those old tests that I just mentioned. And the specificity, the specificity of the CB caps called BC4D, that's where the C4D complement binds to the B cells of the body. It has the same specificity for lupus as anti-Smith and anti-double-stranded DNA. Much better test. And when I get the results of the test back, this is what the test results look like. And I like to just kind of bring you through this. And by the way, any rheumatologist can order this test on patients that they suspect the diagnosis of lupus in, but it does take some extra work to get it done because most insurance companies won't pay for it. But this is what the test looks like. So in this particular patient in whom it was ordered on, the anti-double-stranded DNA and the anti-Smith antibody was negative, just like in our patient Michelle. But look, the two tests that are listed underneath it, one called EC4D, that's when the C4D complement binds to erythrocytes, which are red blood cells, and then BC4D, both of those were positive. Both of those are very specific for helping us make a diagnosis of systemic lupus. And then they plugged these numbers into their algorithm called the AVISE SLE test, and they were able to show that she had a positive result of 1.4. And then we can look at the graph itself. You see the kind of the blue triangle getting larger over time. The blue represents the number of lupus patients who had that particular score, and then the white above it represents the approximate number of people who don't have lupus with that particular score. So for a level of 1.4, the vast majority of people who had that particular test result, the blue part, are people who actually have lupus. And just imagine, what if her doctors, Michelle's doctors, could have ordered this 3 years ago and had this similar type of result and helped to make a diagnosis of lupus in her. And then at the bottom, you can see that this particular result, it increases the chances of this particular person having a diagnosis of systemic lupus erythematosus. So you can't help but wonder about it. What if her doctors, Michelle's doctors, could have ordered the AVISE SLE test 3 years ago? What if this test would have ended up being positive and they could have told her, yes, Michelle, you have systemic lupus and we're going to put you on hydroxychloroquine, the drug of choice for lupus. We want you to stay out of the sun. Remember, she got that bad flare-up because of beach trips. And we could have taught her not to go to the beach, to wear sunscreen religiously, to wear a wide-brimmed hat whenever she'd go outside. Could we have prevented that optic neuritis in the first place? Could we have prevented her from going blind? And I am convinced that we could have. When we take lupus patients with early disease and we treat them properly, they are much less likely to develop severe lupus. They are much less likely to develop involvement in major organs like the kidneys and the brain, like as happened in Michelle. And could she have actually been in remission now and possibly off of steroids? And the answer is absolutely yes. That could have been her future. She could have been enjoying her life as a high school student, sending in her applications for college, looking forward to a great life in college. But now she's looking at probably getting into college, but having a lot more difficulty with homework, and then having to see me all the time and getting her on better therapies for her lupus. So let's contrast this to how drugs are developed. Remember, I showed you a slide earlier where I made that sarcastic question about, are researchers really that bad? Is technology that bad that we have nothing new since the 1960s? Well, that's not true. Look at this slide here. It shows all of the drugs that have been FDA approved to treat rheumatoid arthritis. Rheumatoid arthritis is a systemic autoimmune disease that's closely related to lupus. And look at all the drugs that have been FDA approved since the 1960s, here highlighted in yellow. And then for systemic lupus, I could add 3 more. And then if we looked at the other systemic inflammatory diseases like psoriatic arthritis, ankylosing spondylitis, I could fill up this graph with even many, many more. So what's the difference? The difference is because pharmaceutical companies, fortunately, have a lot more money that they can put into research and development and navigate the very complicated process of getting drugs approved and brought to the clinicians and to the patients. But the process for getting laboratory tests approved is much more difficult. It's a much harder thing to navigate. If you ask most doctors how drugs become FDA approved, the vast majority of physicians can easily tell you the process, even though they're not intimately involved with how drugs are FDA approved. But ask any doctor how laboratory tests become FDA approved or approved by the Centers for Medicare and Medicaid Services. Very few are going to be able to tell you that answer. And this includes those very scientists and doctors who are discovering these laboratory tests in the first place. For example, one of my friends, Dr. Andrea Fava at Johns Hopkins, amazing lupologist, he is discovering some amazing laboratory tests that could possibly help diagnose lupus nephritis and monitor disease activity by just looking at chemicals in the urine. Just imagine if we didn't have to do a kidney biopsy, but what if we could actually figure things out by these tests in the urine? But guess what? He has no idea about the complicated process of getting his great discovery into the hands of clinicians. And I'm just afraid it's just going to end up being stuck in the laboratory and never get into the hands of doctors. We must be able to change the system. So this slide here, this shows you one way that we can figure out the utility and validity of a laboratory test. It's using a process called the Freibach-Thornberry hierarchy. And Exergen was able to prove that at each of these steps, starting with technical efficacy and then diagnostic accuracy, efficacy, diagnostic thinking, therapeutic efficacy, patient outcome efficacy, and then the highest rung on the scale, societal efficacy, Exergen's AVISE test met every single one of those. In addition, the Exergen AVISE test has been researched by some of the world's best lupologists. This slide here shows the researchers that have been involved with the discovery and validity and the diagnostic accuracy of these tests. But insurance companies are not believing these research experts. This is an example of a denial letter that many physicians like myself get when we order these tests on our patients. This is from Anthem Blue Cross Blue Shield. Even though there's so much evidence about how great these tests are, this is what they say about the Exergen AVISE test. Another term for this test, by the way, is the multiplex auto antigen microarray testing. That's the same thing. That this testing to diagnose and manage systemic lupus erythematosus is considered investigational and not medically necessary. I wish they could have Michelle sitting in front of them and be able to tell her that to her face, because that's wrong. Insurance companies, they can say anything that they want to. They don't have to be able to back it up with any facts whatsoever. Another thing about the AVISE SLE test, by the way, the CB-CAPS test, its patent expires this year, 2024. What's going to happen? LabCorp and Quest, which are the two huge commercial laboratory companies that insurance does send laboratory tests to and they'll pay for, I guarantee you they're going to get a hold of these CB-CAPS technology and start making the lab tests themselves. They're going to be able to churn it out in very high volumes and of course be able to charge less money, because high volumes, you can do things for less money, like the Kmarts and the Costcos of the world. And then patients like my patient Michelle can finally start to get this test. But here it is over a decade later. Just imagine if we could have started using these tests 10 years ago. How many patients like Michelle could have been saved and kept from dying and kept from getting permanent damage like the blindness that my patient Michelle has? So what are proposed solutions? I don't know how to cure this, but I do have some ideas on my own. Number one, the American College of Rheumatology. I love you. You're my college, but you should be doing more. You should be actively supporting novel biomarkers like CB-CAPS. You should be more flexible about conflicts of interest. I mention that, by the way, because I'm an advisor for one small biotech laboratory company, and I'm also involved at the American College of Rheumatology. But because of that involvement, I'm not allowed to talk about this kind of stuff in the committee that I'm on, even though I don't want to mention, at all I don't want to do anything for the laboratory company that I help out. I want to help out all laboratory companies, come to physicians and patients, but I'm not allowed to talk about it because of that supposed conflict of interest. Please, ACR, change that. And they should also include advanced biomarkers and guidelines. The guidelines that we give about doctors diagnosing lupus, they include all those old tests from the 1960s, but they don't mention these much better tests like the CB-CAPs. Experts, what should lupus experts do? They should teach these new biomarkers or laboratory tests to other rheumatologists. They should teach them to fellows, even if they're not available at their institution. So far, this isn't being done. Lupus experts, when they get up on the stage, they teach anti-double-stranded DNA, anti-Smith, but rarely do they teach these better tests. The disease management resources such as textbooks and UpToDate.com, which teaches doctors like myself how to do things, they should support novel biomarkers in disease management discussions. But it's only recently that they even mention these particular tests on UpToDate.com, which is a major online source. And it's only after I started to complain that they didn't have them on there. Finally, they're on there, but it's with some stipulations that I'll mention in just a couple slides. Also, academic centers and community rheumatologists, they should include novel biomarkers in their institutions. So far, they usually don't because, unfortunately, ordering laboratory tests and doing them in your own office, they usually make that institution money. We need to get rid of that money-making part of it. They should be incorporating better tests instead, no matter what. Another recommendation I have is that experts, insurance companies, and rheumatology educational platforms like textbooks and UpToDate.com, they should adopt transparent, objective systems for evaluating the clinical utility for all biomarkers. And this should apply not only to the new ones like CB-CAPs and EVISE exogen tests, but also for the old ones as well. They should all be standing on the same ground. And just for an example, they could use that Freiback-Thornberry hierarchy. And just an example, I'm very happy, by the way, that UpToDate.com is finally mentioning using CB-CAPs in lupus patients. But you know what? They put a stipulation on there. They said, but more research needs to be done, and these tests need to be followed for a longer length of time. Well, that's ridiculous. They're not going to find any studies that are over very long lengths of time, even with anti-double-stranded DNA, anti-Smith, and complements. They should be holding those old tests to the same level of requirements as the newer tests as well. There's a lot too much prejudice and bias going on there. Insurance companies, you should be there to be helping patients. But unfortunately, you put money first way too often. You should be doing more to help patients over helping your shareholders make money. You should be paying for novel biomarkers that show utility in peer-reviewed journals. Just like Exogen has done all those research studies and met all those landmarks in the hierarchy I mentioned. You should be reimbursing proprietary labs and not favoring just the large commercial laboratories like LabCorp and Quest. You know that insurance companies are happy to pay for the test by these two very large commercial tests, but they very rarely will pay for tests from companies like Exogen that are the ones actually out there inventing these better laboratory tests and bringing them to the market. Another one that I haven't mentioned so far is the insurance companies, when they give us denial letters, they always say things like this laboratory test is not clinically useful or it's experimental. But the other thing that they'll say is that it's not recommended in the classification criteria for diagnosing lupus. Classification criteria for systemic lupus is for research purposes only. It has never been meant for diagnostic purposes. And that's something that they clearly well know, but they still use it as one of their crutches, saying, well, it's not part of the classification criteria. But we're talking about patients' lives and diagnosing people in the clinic, not about putting people into research studies. And then the FDA and the CMS, Centers for Medicare and Medicaid Services, you guys are the ones who are supposed to be out there evaluating new laboratory tests and having them approved to go to patients and to clinicians. This whole process is much too complicated and much too expensive for biotech companies to navigate. So please look at your processes and make them simpler and easier for laboratory companies to get through so we can get much better laboratory tests. There's no reason that all the tests that we're having covered by insurance companies are way back in the 1960s. All these tests are over 55 years old, and there's just no reason for that being that way. Now, I wish that everyone that I just mentioned so far, such as the insurance companies, the bureaucracy at the FDA and CMS, also the textbooks, UpToDate.com, and the experts, I wish all of you could be sitting there in front of my patient, Michelle, or patients just like her who have been devastated by this disease called lupus, and be able to explain to her why her diagnosis of lupus had to be made on tests that are over 55 years old. And thank you very much for watching this video today on this very important topic. I hope that whoever you are, whether you're a patient, whether you're a physician, whether you're part of the insurance companies or the FDA or the CMS, I hope that you're able to work inside the system and to be able to fix this broken system so that we can get much better laboratory tests out there to our patients and to clinicians, and hopefully keep horrible things from happening to more patients like happened to my patient, Michelle. Thank you very much for listening to me.
Thank you, Dr. Thomas, for so clearly describing both the current state of lupus lab tests and how they might be improved in the future. We hope you found this presentation informative. Of note, neither Kaleidoscope Fighting Lupus nor Dr. Thomas have any conflicts of interest regarding the content in his presentation, and no current or recent financial association with any of the laboratories or biotech companies mentioned in this video. Once again, a special thanks to our community sponsors, Pharma, Tin Rocket, Blue Eyed Crow Studio, Due North Studios, and 7 Minute Cinemas for their generous support in making this presentation possible. And we want to thank you for watching. We encourage you to visit our website, kaleidoscopefightinglupus.org, and follow our social media platforms for the latest lupus news, program information, award-winning blog articles, and so much more. Thanks for spending time with us, and remember, you are not alone. I'm Annika Hazlitt for Kaleidoscope Fighting Lupus. Please take care.